Good evening, everybody, and welcome to another one of our Napiers webinars. I'm delighted to be joined by Alyssa for the second time. She did do an endometriosis webinar back in February. Sorry.
No, it's okay. This one
is the endometriosis one. We did a hypothyroidism webinar in February. This one is, of course, on holistic approaches to essentially women's health, really. What are the key symptoms and irregular periods that women are suffering more and more, I guess.
And we're going to focus on kind of two of the big ones that I see clinically most often that I think are kind of becoming more widely recognized. But I'll try and mention as we're going through which things are also relevant.
More, I guess.
And we're going to focus on kind of two of the big ones that I see clinically most often that I think are kind of becoming more widely recognized, but I'll try and mention as we're going through which things are also relevant if you maybe don't have one of these diagnoses, but you still have, heavy or painful periods for another reason. A lot of those things that we say will also be helpful.
Fantastic. And just to give you a bit of background for anyone who is coming across Napiers for the first time, we are a 166-year-old herbal medicine and wellness brand. You can see we're live streaming from our shop in Edinburgh. We are still in the same spot that we were back in 1860 when we were founded as one of the leading herbalists in the UK. And we just really want to continue Duncan's traditions of treating the individual using predominantly Western herbs, but more and more herbs sourced from across the world. Alyssa, as you can tell by her accent, is from the Western world, but she's from
the US. Yep.
And so I don't know if you want to give a bit of background about yourself just before we get started as well.
So I am very grateful to be part of continuing the tradition of Napiers. It's a very historic and very cool thing to be a part of as a herbalist from the US. I have been in practice by almost 6 years. Most of that time has been in the US. I moved here 3 years ago, so I've been in practice here for just under a year, about 6-8 months. And I specialize in female reproductive health, autoimmunity, thyroid in particular, and a lot of digestion and holistic health. So I kind of call what I do and the tradition in which I was trained functional herbalism, because I use nutrition, clinical nutrition, supplements, a lot of functional medicine concepts, and also some lab work interpretation as well. And then of course, herbalism. And then also, crucially for our presentation tonight, we're going to talk quite a bit about blood sugar and exercise and movement a bit as well. So I have a movement and strength coaching background as well.
Brilliant, fantastic. Well, that was a really good run through about Alyssa. We would love for you guys to be part of the community and be part of the webinar as well. So do pop your questions into the chat as we're going along. If Alyssa doesn't get to them during the webinar, if the content doesn't cover your questions, then we'll be sure to answer them at the end. The webinar itself should last about 45 minutes with about 15 minutes for Q&A. Just to be completely transparent, we have overrun the last few times that we've done webinars just because there's just so much depth and content to cover, and we do want to try and get to as many questions as possible. It is also being recorded, so if you have to dash and can only watch part of it, then you will be sent a recording once we've had a chance to edit it and upload it to our various channels. And because you're part of the mailing list, you will get that sent to your inbox once it's ready. So without further ado, I wanted to say welcome to our webinar. And Alyssa, let's take it away.
Sure, cool. So like I said, I'm from the US, and I just want to sort of give a shout out and credit to my teachers in this area before I get started, Erica Galentine and Thomas Easley. Herbalism is a medical profession that is in the US at least very much still lineage based. So that's sort of the teaching lineage and the knowledge that I come from. A lot of it comes from them. So like we said, what I'm going to cover today is going to focus primarily on endometriosis and PMOS, formerly known as PCOS. We'll talk about that name change a little bit as well. So we're going to talk first about what's happening in the body. I am, not surprised, but, it's unfortunate to me that some folks, who have been struggling with these things for a long time, it's difficult sometimes to get good quality information about what's even happening. So we're going to start with like what is happening and what is about hormones, what's not about hormones when it comes to endo and PMOS. Another thing that I specialize in and that I feel really passionate about because it's been part of my personal health journey is pain and pain management. So, pain neuroscience, we'll talk that could be 3 webinars of its own. So I won't go too deep, but, the severity of these, the tissue damage or the lesions and things is not necessarily related to directly to how much pain someone is experiencing. So that is an important, I think, connection for folks there about, whether or not their version of it is quote unquote bad enough. There's an important component with chronic diseases like endo and PMOS that, we are managing expectations. We are managing a chronic disease. So, both endometriosis and PCOS, PMOS, we can't really cure them. So they're a chronic disease. We are doing, you can definitely regain a lot of quality of life and a lot of reduction in symptoms, but it's not going to be something that you're not, you don't just like fix it once and then you're good for life. So it's something that requires ongoing management. Oh, sorry. I switched you. And then of course we're going to talk about herbs. So we're going to talk about, what I call like therapeutic priorities for both endometriosis and PMOS. And then also because I have a bit of also a medical sociology background, there's it's important to me to sort of zoom out a little bit to the sort of wider social context of some of these things. There is, we'll talk briefly about like male medical bias and why some of these diseases that affect people with ovaries are, underdiagnosed or they're diagnosed late and our treatment options are quite limited. So without further ado, let's talk about endometriosis first.
Just 2 ticks.
Yeah.
We've got a few comments
audio.
just about some audio issues. But it looks like most people can hear. Alice, I'm really sorry if you can't hear anything at the moment. I appreciate me talking probably isn't going to help you. But hopefully you can get them resolved. We will obviously send the slides out, so that will help. Sorry, the recording out, so perhaps that will fix your audio issues after. It may be worth trying to leave and enter again and just check if there's maybe an update for your computer or something like that. But yeah, apologies about that if there are any issues. It looks like most people will be
can hear. Most people, yeah. Sometimes that happens if you exit and re-enter it'll fix it. Okay, so what is going on with endometriosis, right? We don't know why this happens in some people's bodies and some people don't develop endometriosis. They think the working understanding at this point is that sort of what you might call like a triggering event is something called retrograde menstruation, which is when small amounts of menstrual blood sort of backflow into the fallopian tubes. And for whatever reason, in some people, there is a genetic component, but for reasons that we don't completely understand, in some people that triggers them developing endometriosis, and some people it doesn't, because again, it happens to most people who menstruate. But some people develop endometriosis and other people don't. They also sort of now there's more and more research coming out about like the immune involvement and the impaired what herbalists would maybe frame as like lymphatic clearance, and by that I mean the sort of removal of metabolic waste and tissue and dead tissue. So some combination of retrograde menstruation kind of triggering this. Someone has, for whatever reason, genetically or otherwise impaired clearance, and then lo and behold, endometrial tissue, which is the tissue that lines the uterus, starts to grow outside of the uterus. And this becomes problematic because endometrial tissue acts outside the uterus the same way it would inside of it, which is that it responds to estrogen. So it thickens and breaks down and bleeds and sheds with each menstrual cycle. So you have all of this excess tissue, and it, unlike inside the uterus, right, where there's an exit route, there's nowhere for it to go. So it will, it causes a lot of chronic inflammation, right? You may have heard, if you have this, you may have heard or read about like prostaglandins. And prostaglandins are an inflammatory mediator, so they're involved in this process. So the the feedback loop is this lesion, the lesions, and they can be, on the bowel, they can be in the pouch of Douglas, they can be, on the fallopian tubes, they can be, pretty much everywhere. They found them as far away as like that somebody had them on their lung once. So yeah, they can get, quite widespread. And, the issue is the lesion produces inflammatory molecules, especially prostaglandins was one of the big ones. That increases something called aromatase. The aromatase makes more estradiol, and then the estradiol makes, which is a form of estrogen, it's a very strong form of estrogen, that makes more prostaglandins. So one of the issues here is that while you do not have, usually people have normal estrogen and progesterone blood levels, serum levels. Locally, there can be elevated estrogen, which unfortunately creates this, not positive in the sense that it's a good thing, but positive in the sense that it accelerates and builds on itself, as opposed to, right, positive feedback loop, negative feedback loop. So it sort of upregulates itself through that cycle that I just mentioned. So you'll have a local concentration where estrogen is higher because the lesions themselves are also contributing to more local estrogen production. So it can be much higher within those lesions than systematically, which is why someone's bloods can appear normal. What that means for the lesions, right, is that they it makes them proliferate more rapidly. It helps them survive, and it causes a whole lot of inflammation. Because again, that tissue has nowhere to go, and so there's waste products kind of floating around in the pelvic cavity, and it's difficult for the body to deal with that because it's not looking for it there. So this can cause, a lot of times, I see this a lot with a lot of bowel problems. So people will have a really painful bowel movements or constipation. It can cause cysts. It can cause scar tissue and adhesions, right? So adhesions are when the tissue causes changes in the way that connective tissue lays down, and so the pelvic bowl is held up by this sort of sling of connective tissue, and so when you mess with that, you can get imbalances in pelvic floor tension, which can in of itself be quite painful. So as I mentioned, I think it's important to say that the amount of pain that someone is in because of their endometriosis is not necessarily indicative of how severe it is. So you can have, just a little sprinkle of it somewhere and be in a lot of pain, or you can have you can have lesions everywhere and not be in pain, much pain at all. And that has to do with pain neuroscience. So pain, which is again sort of a topic that we don't have time to get into, but it's very fascinating. Pain is a phenomenon that is manufactured in the brain. The brain tells the body how much pain it needs to be in, and that sort of report that it sends the brain is based on a lot more things than just what's happening locally in the tissues that it says are painful. So that doesn't mean that it's not real and that someone's pain isn't real. It's just to say that with chronic pain conditions, one of the things with clients and patients that I think is an important conversation to have is that you kind of have to click out and kind of disconnect. The severity of the pain does not necessarily directly correlate to how much physical tissue damage or inflammation there may be. So that's not to say it's not real, but it is to say that you shouldn't necessarily be more worried about it if it's painful than if it's not, if that makes sense.
I suppose it works in reverse in that some people might not be experiencing as much pain, but actually the level of scar tissue and cysts and adhesions could potentially be a lot worse than someone who is experiencing more pain.
And their fertility, they might not know, and their fertility might start to be affected. And they might not, again, if they're not in pain. So it is, if you have, usually there is at least some pain, or there's,
indicators.
The bowel problems, the periods will be painful. They'll be, heavy. There'll be pain at other times of the month apart from the period. Because again, especially if someone has like lesions or adhesions is what I meant to say, or scar tissue, then that's going to be something that potentially affects them at other times, not just when they're bleeding, but usually there's at least some pain during the period, unfortunately. So
just a question. if someone has been experiencing these symptoms and complications right from when they were first having periods, does that indicate that they're likely to have endometriosis from when they first started going through puberty and started having these kind of hormonal changes, or is that normally linked as much from early kind of puberty?
Yeah, I mean, if someone has been having, painful periods, irregular periods, pain during intercourse is another really big one. Pain during bowel movements is another really big one. Since the beginning of their bleeding, then it's definitely worth getting checked out. So one of the issues with endometriosis up until very recently has been that the diagnostic process is quite invasive. So really quite severe endometriosis, you can see someone with the skill can see on an ultrasound. But if it's mild, it's not really, they don't use just an ultrasound to you can't really, it's not really a reliable diagnostic, so they have to do like laparoscopic surgery to really make sure that it's there. And so obviously that's a very invasive diagnostic process. So that's one of the reasons that people go a long time without potentially being diagnosed, is because it's like to get,
and especially if you're young in that case, you don't
have surgery when you're 15 if you don't, so yeah, so it's very understandable that people are hesitant. Now they're starting to, there's a potential mRNA like saliva test that's kind of in progress in the UK. I think it's showing a lot of promise. And ultrasounds, like I said, are still an important part of the diagnostic criteria, but hopefully, it's usually diagnosis, right, is this really delicate sort of triangulation of, symptoms, health history, and, these diagnostic methods like, ultrasounds and laparoscopies and things like that. So, but yeah, if someone has sort of always had problems with their period since they started bleeding, definitely worth checking out, because someone who is, especially someone who's young, it's, irregular periods when you're really young, that's quite normal. Irregular periods when you're, and even like ovaries that are a little bit cystic, like that kind of can come and go sometimes, that half the time that resolves itself. But if there is other sort of corroborating things like pain during bowel movements, like pain during intercourse, like signs of insulin resistance, which we'll talk about when we talk about PMOS, then it's definitely, worth getting checked out. Because yeah, I mean, better to get it checked out than better to get it checked out than So last thing on this slide, some of your actually we'll talk a little bit more about inflammation when we go into therapeutics as well. But again, that cellular waste that is with that tissues that are growing, secreting, and dying with nowhere to go, with no exit route, causes a lot of inflammation, right? So the body and the immune system gets involved. There are immune changes that have been noted, and like I said, in endometriosis as well. So the inflammation gets involved because there's a bunch of cellular and metabolic waste hanging around, and the body doesn't like that, right? So you'll see when we go to focus on herbs, a lot of our focus is on pain management, yes, but also on something that herbs are actually really uniquely qualified to do, which is support the lymphatic system. So we'll talk a bit more about that when we get there. But again, complications that can come from this, a lot of times people what will lead them to seek out a diagnosis is painful periods, pain during intercourse, pain during bowel movements, really heavy periods. Oh, that's not always the case. The periods are usually quite heavy, which can lead to anemia. So that's another complication you need to be aware of. Especially if someone doesn't eat meat, you're at a higher risk of anemia. Digestive issues, again, these lesions, those tissues, other tissues in that area get affected, right? So those tissues, they're separated by thin sort of membranes and connective tissue, but they're right next to each other. So they something that's got lesions on it next door is going to start affecting your bowels, and that's one of the things I see a lot is problems with bowel movements, infertility. Yep. So sometimes nausea, sometimes the pain can be so bad someone's nauseous and throwing up and vomiting and all of that stuff. So when we get to therapeutics, we'll talk a little bit about some stuff for each of those. So
we have got a couple of questions. Yeah, we're doing fantastic. One which we might have to come back to at the end is a little bit less topical to what we're discussing right now, but it's what about adenomyosis that often occurs with endometriosis? Do you want to park that for later, or do you want to answer it now?
Yeah, so a lot of the same things that herbally I would use for endometriosis, you would use for adenomyosis, because I see adenomyosis less often, but it is something that I think is becoming a little bit more widely recognized as well. Adenomyosis is when you get changes in like the thickness like you actually have those lesions and things in the muscular wall of the uterus. So the difference between and it's a different pathology that leads to it as well, I think. So I don't see as much adenomyosis, but some of your pain management things are going to be very similar. And I would say also because, again, you have, more tissue than you should somewhere ideally that it's not necessarily meant to be, gently supporting the lymphatic system and your sort of your clearance and your housekeeping mechanisms are going to be really crucial for you as well. Yeah.
Brilliant. And then a question from Marza is there a genetic element to this? So if you're likely to have it, are you going to pass it down to your daughter? Or if your mother has had it, are you likely to have it?
Potentially. I think there is a genetic link in terms of if someone gets it, in their family lineage, because again, we don't actually know why some people, because everyone who menstruates will probably have what's called retrograde menstruation at some point. And some people that causes them to develop endometriosis, and some people it doesn't. So I think there is a genetic component. There's also genetic changes once someone has endometriosis. There's changes in their gene expression, which is why that new test is the new diagnostic test where it's like an mRNA test of the saliva is like really promising and cool. So yes, but I will confess that I don't have the genetic sort of proclivities and like at the top of my mind. Yeah. Good questions. Yeah. Okay. So my teacher, Erica Galantine, from whom I learned much of what I know about the female reproductive system, has a metaphor of she used to call it like a plate of spaghetti, which especially when we're talking about PMOS, again formerly called PCOS, I think it's really helpful to keep this in mind, because there's a temptation with anything hormonal, and particularly anything hormonal in the female reproductive system, to sort of look for the one lever that we can pull and fix the things, right? Which is a totally understandable impulse. It's just unfortunately more complicated than that. So we recently had sort of a landmark, it's the result of like a long, I think it's like over 10 years, they've been advocating to change the name, but it's been sort of officially renamed, in the process of being renamed, PMOS, from PCOS. So it used to be called polycystic ovarian syndrome. Now it is polyendocrine metabolic ovarian syndrome. So there's a couple of reasons why this is exciting, if that's not an odd word to use. First and foremost, it's destigmatizing, because the word cystic isn't actually accurate, as we'll talk about in a second. And is also a little bit, when someone hears that, or when, applied to them, it's like, it doesn't, that word has a little bit of a stigma attached to it. So, it's destigmatizing, which is important for people in the mental health side of managing a chronic disease. And not only that, it also is more accurate to remove the word cystic, because they're not actually cysts in the ovaries, right? So one of the diagnostic criteria, we'll talk about this on the next part as well, it's called the Rotterdam criteria. You have to have 2 out of 3. One of them is that you have sort of what's called polycystic ovaries, which means you have, again, they're not really cysts. What they are is multiple underdeveloped follicles that are recruited because of blood sugar issues usually, right? There's it changes the hormone metabolism and like hormone pulses, and causes the brain to tell the ovaries to keep making follicles and keep recruiting follicles, but they don't fully develop. So normally it's like a like a gladiatorial competition thing where like 3 of them are recruited, 2 of them die off, 1 of them is chosen to go forward. And so basically you have too many follicles that are being recruited, and you'll get oftentimes on the scans, you'll get what they call like the string of pearls, which is where you'll see this little line of underdeveloped, sort of almost like aborted follicles that have been recruited, and they started their development, but then they kind of died off, and they didn't finish it. And so that causes a whole host of problems because the ovaries and the follicles themselves are actually endocrine glands. So they are during someone's menstruating years, they are where the primary sources of our estrogen and our progesterone secretion. So that's problematic if that sort of process is messed with. So I want you to think about this in terms of like ecology, right? And John Muir said famously that, you know, when we pull on one string, we find it, some version, I'm paraphrasing badly, but when we pull on one string, you know, we find it connected to everything else, right? Like that's how ecosystems work. It's also how, you know, more and more we're understanding it's also rather how the body works. And I think it's a particularly good metaphor for PMOS because it is quite complex. So the other thing that, but key to this is PMOS also more accurately points to insulin resistance as like a central driving factor, as a key driver of this. They haven't really, you know, I don't know that they have definitively figured out that. I wouldn't say it causes it, but it makes it worse, and it potentially sort of sends it into, again, this positive feedback loop. So the Rotterdam criteria, in order to be diagnosed with PMOS, you have to have at least 2 out of the 3 of the following. So again, polycystic ovaries, anovulatory cycles or absent periods. So anovulatory cycles means you have a menstrual cycle, but you don't ovulate, or your period is absent altogether. It's important to you know, eliminate other causes why someone wouldn't have a period too. There's can be other things that cause that as well. And then androgen excess, so or hyperandrogenism, which usually is diagnosed oftentimes is diagnosed via symptoms. So hirsutism, which is hair growth. I think I put that I should have put androgenic alopecia on here instead of male pattern baldness because it technically has its own pattern. But so, you know, acne, weight gain, baldness around the crown, you know, like thinning hair around in a very specific pattern, and then hair growth, you know, in like the, you know, like on the face, on the chin, things like that. So again, this polyendocrine, right, more than one endocrine, which means insulin is also a part of the endocrine system. So there's more than one endocrine system involved here. So when we think about it as an ecology, it kind of helps us avoid the temptation to sort of find one lever and pull on it. So when the follicle fails to like complete its cycle, the corpus luteum isn't formed. So again, I'm sorry, it's very jargony, but the corpus luteum, after someone ovulates, what's left over is called the corpus luteum, and that becomes the gland inside the ovary that secretes progesterone. So when someone has PMOS, when the follicle doesn't complete the cycle, it doesn't secrete progesterone. So you need progesterone in order to complete the menstrual cycle. And so this leads to an excess of follicles, and then there's too much estradiol usually being secreted as well. So you know, insulin resistance is absolutely one of the central drivers of this. There's a high level of comorbidity with metabolic syndrome, which is important also to note that like that occurs in individuals, insulin resistance in particular occurs in individuals with a low body mass index. So obesity does increase the risk and the statistical risk that this will be an issue, but it does also happen in folks with what's considered a normal BMI. So it does affect, you know, again, so, you know, not ovulating is one of the main things, infrequent cycles or really long cycles, because again, one of the indicators of how long your cycle will be is your luteal phase, which is the second half. And so if you're not producing progesterone because you don't have a corpus luteum, your cycle lengths will be potentially really long. And again, hirsutism, weight gain, hirsutism being the hair growth, scalp hair thinning, and, you know, again, it does affect your fertility because you're not ovulating. Or you're ovulating maybe very infrequently, and sort of sporadically. And you know, that overcrowding in the ovary is also not great for fertility as well. There's too many cooks in the kitchen, if you will. Yeah. So my teacher, Erica, refers to this as like the hormonal soup, which is like, just to illustrate again, to emphasize again, like just the complexity of trying to identify a single hormonal cause here, that's one of the reasons that like polyendocrine metabolic ovarian syndrome is a more accurate, a better name for it, because it really, again, sort of helps point us away from just, just taking Vitex, for example. Like that's probably not going to fix it. So I realized that I kind of skipped over one of these pieces, which is androgens. What are androgens? Because it's a word that you probably have heard if you suspect that you have PMOS. So androgens are a family of sex hormones. Testosterone is an androgen, and they serve as precursors for both, androgens serve as precursors for both testosterone and estrogens. So all of your sex hormones are made from cholesterol, which is one of the reasons you can't, that people who are under feeding calories will lose their periods, and their menstrual cycles will be affected. And so you kind of have two branches. So cholesterol turns into a word I can't remember, which turns into either androgens, which then go down to testosterones and estrogens, or they can also get turned into progesterone. So, but all of it starts with cholesterol. We're
doing great. We have got a question on this particular topic. Lots of other questions, which are fantastic. But is androgen excess genetic? Does androgen excess vary between ethnic groups? And are there any remedies to reduce this excess of androgen?
Yeah, so we'll talk about remedies a little bit later, so I'll hold that part of the question. But it's a very big question. So to my knowledge, androgen excess in and of itself isn't genetic, but because there is a genetic component to both metabolic syndrome and proclivity towards insulin resistance, I would say if either of those are in your family lineage or your genetic lineage, then you would you would potentially be at a higher risk. So I would say
the factors which impact it are genetic, but actually in itself.
The androgen excess in and of itself is to my knowledge, not genetic, but again, the things that potentially cause or drive and someone to develop androgen excess there's sometimes that genetic. And to speak to the point about the ethnic group question, also epigenetic, right? So epigenetics is when we see changes in people's gene makeups as a result of their environment over generations. And so that sounds more complex than it is. It's more intuitive than that. It's basically, right, when you have populations who have been disadvantaged or oppressed over many generations, you see changes in their gene expression because our environment, and that's the study of that is called epigenetics. So we're sort of understanding more and more about how our environment shapes our genetic expression. And your genetic, right, your nutrients, like your nutrient status can influence your genetic expression across your life. And then that would also, obviously, if you had offspring, then that would affect the sort of baseline genetic expression that they are starting with. So one example, I just wrote a course on inflammation, and we were talking about chronic inflammation and how certain factors, including diet, including environmental toxins, right, all of these, including allostatic load and stress, upregulate certain molecules that then go into your cells and change your gene expression towards more inflammatory gene expression. So that process can be sort of copied and pasted over generations, right? And so to that extent, I don't know the statistics, but there would absolutely be variations in across ethnic groups because of environmental factors over generations would be my answer to that. Yeah. Other questions just now?
I think we're good. We can come back to the rest at the end.
Okay. So one last note here, not to just like throw more theory at you, but it is important to kind of again, obesity does increase your risk of this. There is often thyroid involvement, which is again an endocrine system, and so this really is polyendocrine. It does come with a higher risk of miscarriage because progesterone is what helps hold on to a pregnancy, and so when progesterone is not up to it's not doing what it needs to do, you have a higher risk of miscarriage. Adrenal function is normal, and progesterone can be normal in an absolute sense, right? So your progesterone is not low; it's just low in relation to estrogen and your androgens. So, right, estrogen and some of your androgens, especially your stronger forms of testosterone, they kind of need a break. They need like a break in terms of like a car break. Like they need to be kept in check because they'll put the gas to the floor and run if they're kind of allowed. So progesterone acts as sort of a
Counterbalance.
yes, exactly. Yeah, thank you. A counterbalance to that. So if someone's progesterone can technically be normal, but not up to snuff because the estrogen and the androgens are so much higher. So that's the difference between an absolute hormonal deficiency and a relative hormonal deficiency. So an absolute deficiency, right? It's too low, full stop. A relative deficiency is that it's too low compared to what it's having to try and put the brakes onto. Yeah.
And it really goes back to the point you were making about feedback loops in general, and that's how hormones work across the body, is one pushes, the other has to pull.
Yeah.
And that balance is really key and really important. So we do see that a lot for just lots of different health issues, but in particular, this one is so focused on estrogen and the associated hormones that the impact is much greater.
Yeah, and it's really complicated. So it's this like 9-dimensional, the thyroid gets involved, insulin gets involved. So that's really, it's like I think the easiest way to understand it is to sort of focus in a bit and zoom in a bit on this relationship between estrogen and progesterone, which is a very key central kind of tug of war that's happening. But again, it's and if you can kind of address what's happening with insulin, you can usually smooth some of that out. But yeah, there's LH, there's FSH, there's the thyroid, it can get really again, to go back to my point about like it's to remove the temperature, my sort of overarching point is like it's the way we work with it doesn't necessarily require us, and to make it better doesn't necessarily require us to like find a hormone lever and pull on it. It's more about the ecology of it. And so like I think it can be especially distressing, when someone has maybe just received a diagnosis or is about just trying to figure out what is going on. It can be, you want to understand. I think there's a natural impulse to sort of try and understand in a lot of granular detail, which again can be valuable, but it can also
you can kind of get lost in,
you can get lost in the nitty gritty, and you don't actually. I think my other is like you don't actually need to in order to understand what you need to do. So again, I'm all for education. I'm a herbalist. That is a big part of what we do is education and sort of explaining different body processes. This one is just really gets really complicated really quickly. So yeah, but yes,
and particularly for someone who's trying to kind of improve their symptoms, is you don't want to get caught up in more stress and complexity around the illness or the condition just because you want to know more about it. Really, it's the inputs that are going to have the best output.
Yeah, and I think there's just a balance, and what I notice is that I think for every patient that's a little bit different is like how much how much of the textbook understanding they want and need and benefit from. Some people I think, want and need a little bit less. Some people really want to understand the nitty gritty to the point where it's like, you almost have to kind of help pull them back from that and say, this may be, causing like a rumination or like an overemphasis. So yeah, but definitely all of those responses are like valid and understandable because it's a complex thing.
Yeah, and that is the other thing, is it is the most complex organ in existence. It is responsible for life and for many other things. So yeah, there is just inherent and innate complexity to the organ itself and all the mechanisms within it.
Yeah, which actually segues, thank you, Arjun, very nicely into my next point about male medical bias and sort of the difference in levels of understanding that we have. Like I said, I have some background in medical sociology, and so we at the University of Edinburgh. So this impacts both our level of understanding about female biology on a super basic level. The historical exclusion of female bodies from medical research has led to a very significant gap in our level of understanding about fairly basic things, right? So that comes down to like the presentation of disease. A famous example when speaking about this is the way that heart attacks present differently in women and men. And that leads to heart attack symptoms being missed. And it's much more dangerous for a woman to have a heart attack because it's much more likely that their symptoms are going to be missed. So, at a very basic level, presentations of diseases, how drugs affect female bodies. There is, I think it was only a couple of years, it was less than 10 years ago that the US, I think it was 2018, that the US finally mandated that you had to include women in clinical trials. Before then, it was optional, right? And the rationale has changed historically over the years. But the female cells in a lot of organisms, including in like animal studies and things, it is harder to isolate variables. That's true. But I think it's just sort of been used to justify this, like it's not as well studied. Diseases and things that affect primarily women are understudied. The research is less funded. It's harder to design clinical trials. That's true. That leads to a limitation in the understanding of disease, and then also a limitation in our treatment options, right? As many of the women that have come to me have, expressed frustration over the years about, really the only thing that you can be offered for most things that is still hormonal birth control, which again can be life-saving care. I am not saying that it is not. But it is a bit more limited, and it usually does a decent job of covering up the problem, which again can be life-saving. I'm not saying it's not, but it doesn't really help someone solve the problem. When the old adage is like, when the only tool you have is a hammer, everything looks like a nail, applies to hormonal birth control. So again, there's sort of both this overemphasis and underemphasis on hormones. So everything is something, a woman comes in with something that's wrong with her, and sometimes it's like automatically attributed to hormones, and sometimes it is, and sometimes it's not. So this on a very basic level, that sort of medical research and that gap in the knowledge that we have affects things like our treatment options for things like PCOS and endometriosis. Especially the second thing that's relevant to our conversation about two conditions that are characterized by high levels, sometimes of pain, is that there's a historical, what's called the hysteria discourse, where women's, symptoms are underplayed or dismissed. And so that can be very dangerous. That does have a significant ethnic component. Women who have been racialized as Black are the most likely to be dismissed in a hospital setting. So again, that's especially when we have conditions that encapsulate, they have like a pain component, that can particularly be something that really impacts people. So I won't read this quote out. This quote is from a really good Guardian. It's from a good paper that comes from a really good Guardian article on male medical bias. The article is actually down at the bottom. It's called, do mad people get endo, or does endo make you mad? Which feels like it encapsulates this like quite perfectly. So again, this gap, is sort of back explained in this way that is unhelpful for the future of understanding of diseases like this one, I guess, in short. Yeah.
No, that's extremely interesting. And I think what you'll see more and more now, hopefully with more females in healthcare roles, is a better empathy for those symptoms and for the pain level of pain as well, hopefully, as that balances out over the next few generations, hopefully.
Yep.
But that there is still going to be a bias there, because often those female healthcare practitioners are also being taught based on all of the studies historically.
So that is
again another feedback loop. Negatively.
Exactly. So the foundational studies that a lot of things are based on excluded women. So they did not, the big, really heavily cited longitudinal studies, for example, did not include women for the first 40 years that they ran. So some of our big sort of like landmark pieces of research didn't include any women. There's a really funny example, and that's not funny, but example in the Guardian article on male medical bias, about like, it was a study about it was like a study about birth control, and the study did not recruit any women, or something truly absurd that it was like, oh wow, okay, yeah. So anyways, yeah. So again, exactly that. It's going to affect us, and we have to kind of know that and try and close that gap. Yeah,
absolutely. And the other thing is just the last point, obviously, pretty much coming from me, but definitely advocate for yourself when you're in a medical situation. Obviously, try and convey as much as you can, because you are the kind of person going through the symptoms. So
no, absolutely. Yeah. Okay.
Don't feel like you have to be dismissed, basically.
Yes,
Ultimately.
yeah, and it can be really hard to do that when you're, when you're not feeling your best. So, people around you can, hopefully there's some people around you that can also help you advocate in those situations as well. Okay. How are we doing for time? Are we doing okay?
Yeah, we're at
Okay.
about 45 minutes
Okay. Okay.
that we started. So
I'll do these justice, but I won't rush. I will also won't rush. So, for holistic management of endometriosis, like I said, unfortunately, there is no cure. So our primary priorities are management and support for orthodox treatments. So, what people choose to do about their endometriosis is obviously completely within their hands. Typically, the orthodox treatments include laparoscopic ablation, his partial or full hysterectomies. So my job as a herbalist and as a functional medicine practitioner is to holistically support the body in doing the best job that it can do in dealing with that additional strain of that excess of tissue and cellular waste. One of the first big priorities to sort of kind of try and intervene here and stop this positive feedback loop. One of them is to try and curb the inflammation. Some of your NSAIDs, right, your naproxen and things like that are often used here, and they can have negative side effects, especially when used over time. Herbal ones tend to not, they will curb the inflammation. They're not going to be as strong as like a naproxen, but they also don't have the side effects that stuff will have over time. So we have a really great product. It's a curcumin and boswellia capsule. I like that as a capsule because turmeric and boswellia and ginger is another good one in a bit larger doses, and so the capsules help you achieve a bit larger dose. You would have to just drink a lot of tincture if you wanted to do that, and because boswellia is a resin, that tincture has to be really high alcohol percentage. So it just capsules are just kind of the way to go for that. So some important things, that is curcumin and boswellia capsules are a direct, they basically work on the same mechanism that an NSAID medication will. They are COX-1 and COX-2 inhibitors. So that is a direct sort of, unplug drug, plug in herb situation, which I, don't advocate for a ton, but it is helpful here. Another really important thing for inflammation and supporting your body's ability to resolve its inflammation on its own is by providing enough omega-3s, specifically EPA and DHA. So again, omega-3s could probably be its own class, but I will say that it's important to specifically look for EPA and DHA. Other omega-3s are not as well studied, and they're not, your body has to try and kind of convert them anyway. So the best sort of use of your resources is going to be one with a high proportion of EPA and DHA. And if it doesn't say it on the label, it probably doesn't have much in it. If it just says omega-3s, it probably doesn't have much or very little EPA, DHA. So that's a lifelong thing. You can also achieve that. You can achieve that through supplementation. You can also achieve that by tinned smallmouth fish. So sardines, mackerel, really good for that as well. Something that I have used post-surgery to great effect is therapeutic fasting. That's not for everyone. That comes with a whole kind of list of caveats. By therapeutic fasting, I mean water fasting. Should really only be done for a couple of days if someone is otherwise nutritionally replete. Longer than 3 to 5 days, you'll want to do it under supervision, and there are clinics that will help you with that. That sort of, and you don't have to sort of do it all at once. You can kind of step down. So you can step down, do a week of cooked veg, do a few days of raw fruit, and then start your sort of water fast for a couple of days, and then kind of do the same thing on the way back up. So that can be helpful as an anti-inflammatory mechanism, especially following surgery. It can help with recovery. One of the reasons for that is because when you go into a fasting mode, your body increases sort of apoptosis. It goes around, there's a term I'm forgetting, but it goes around and scavenges the body for dead tissue, and it basically cleans it has like, it initiates like a deep clean. So that's one of the reasons it can be helpful for inflammation. Like I mentioned before, one of the other really big priorities with endometriosis that herbs are absolutely uniquely qualified for, to my knowledge, there is not a drug that does what herbs can do in this area, is to support lymphatic clearance. You want to support circulation as well. So your circulatory stimulants like ginger, a little bit of cayenne, prickly ash, so xanthoxylum is a nice one. That just little doses for that one. You don't need a lot. And then lymphatic clearance is like a big priority here. Lymphatic clearance, you can go, because it's sort of, we're playing a long game. Your gentle, what they're called alteratives, like violet, cleavers, chickweed, calendula, burdock are going to be excellent allies here. Red root is another really good one. It's a bit of an endangered plant, so you want to use it, with intention. It's also a bit stronger. And then, in clinic, I work with a lot of the stronger pain herbs that are sort of Schedule 20 prescription only. But, in the US, we use a lot of, one of them here is poke, in combined topical poke with castor oil pack. So, we have a castor oil pack, and you just use that with a piece of wool, what's it called? It's like a square of like thin wool and almost muslin. Yeah, it's kind of like a muslin. Yeah. And then you would warm that up, and then that's a topical lymphatic support. So again, lymphatic clearance works great as a tea. So a lot of these work great as a tea. Violet, cleavers, chickweed, calendula, burdock work lovely as a tea. So ours is actually a skin tea. We'll talk about it when we talk about POS. I really like our skin tea. That's got a lot of cleavers in it. Your detox tea will also be helpful because it's got some dandelion leaf in it. But yeah, you really want to focus on lymphatic clearance, and explaining the lymph system would probably take me another 45 minutes, but know that it is sort of the one of the big housekeeping mechanisms, and also immune mechanisms, but in this case, housekeeping mechanisms, in the sense that its job is to go around and look for damaged tissue, dead tissue, break it down, sweep, get it, go, like take it away. So because those lesions have no exit route, that's really important in endometriosis. And because someone is oftentimes bleeding heavily, supporting the blood with making sure that to address any anemia. Mineral-rich herbs like nettle and oat straw can sort of support and build the blood. Molasses is a nice one as well. It's very rich in minerals. And then, of course, pain relief. So one of the safest things that I can tell you for pain relief to a room of people that I know nothing about is magnesium glycinate. Magnesium glycinate is, I would say, preferable in my experience over other forms of magnesium for pain management specifically, because the glycine that the magnesium is attached to helps down-regulate pain signaling at the spinal cord level. So you're getting the benefits of the magnesium, and then you're getting additional benefits from the fact that it's attached to a glycine molecule. Herbally, Dalos is a wonderful one. Jamaican dogwood is a wonderful pain herb that you can try over the counter. We have both of those. Jamaican dogwood is a little bit more sedative, so just, try it at home and don't do it right before you have to drive a motor vehicle for the first time. Cramp bark is excellent. This is one of those ones, like I was mentioning, if someone has a painful period, but they maybe don't have endometriosis and their period is just painful for sort of a quote unquote normal reason. Cramp bark. It's called that for a reason. It is really great for menstrual cramps. So there's viburnum. There's two species of viburnum, prunifolium and opulus. So there's cramp bark and black haw, and the cramp bark is a little bit more specific to menstrual, like the pelvic area. But black haw, if black haw is what you can get your hands on, also will work really well. Depending on where you are, CBD is also a great one. And California poppy, which is one that acts very, very weakly on the endogenous opiate receptors, very, very weakly, not in any way similar to like as strong as like an opiate medication. So, but can be helpful, especially for sleep pain, pain that's keeping someone from sleeping. Your stronger pain herbs, there are stronger pain herbs than that, but I'm not going to tell you about them because they are Schedule 20 and I cannot give them to you. So if you happen to not be in the UK and you're in the US, or you're somewhere where kava is legal, that could be another really great one. Yeah, so just, stick with what, what's around, like what you can get your hands on, and you can, chamomile in a pinch is also great. It's a good antispasmodic. So a note here on red clover before we move on, because red clover is a fantastic, I don't think I have it on here, but I meant to put it on here. So red clover is a fantastic alternative lymphatic clearance. People sometimes get scared of phytoestrogens, but phytoestrogens can actually, in many cases, be really helpful, particularly in estrogen dominant conditions, because they occupy the receptor site and block stronger forms of estrogen from activating the receptor. So they can actually be helpful. It's called competitive inhibition. So they prevent the stronger estrogens, because not all forms of estrogen are equally strong, from binding and activating that receptor. So, and then if I had more time, I would talk about gut health, because hormones are excreted in the bile and then reabsorbed. So work on your gut health. And we'll talk a bit about that when we talk about PCOS or PMOS.
Brilliant. And just to add on to that, I don't know if you're going to make a point on the next slide, but a lot of the herbs that Alyssa mentioned can be bought individually, but if you're wanting to get them blended up and a bit more tailored towards your own health requirements and your own diet and your own lifestyle and all the rest of it, you probably should see a herbalist, whether that's with Napiers the Alyssa or one of our other herbalists or someone else, but seeing a practitioner who's able to advise more competently on dosages is very important. You can pick and choose some that Alyssa's mentioned, but if you're wanting to have something which is all-encompassing, then obviously we would advise you to speak to a herbalist.
Yeah.
And also if you're on medication.
Yeah. Also if you are on medication, or if you have, the one exception to the red clover rule is any estrogen sensitive cancers. So our history of estrogen sensitive cancers. That's once in our own, which I use extreme caution with red clover. Yes. Okay. So
but otherwise, we definitely recommend.
Yes, definitely. Yeah. So, curcumin and boswellia, omega-3s, magnesium glycinate are key. And then again, so your priorities here, you can kind of take your own knowledge or do your, figure out what might work for you within these sort of therapeutic buckets, if you will, right? So we want to curb inflammation. We want to support circulation and lymphatic clearance. That's a big one. You want to support building the blood because someone is probably anemic or at risk of being anemic. And then you want to do something that speaks to pain relief. So those are kind of your buckets to think about. So we'll do the same for PMOS here and kind of think about this and kind of in, again, buckets. So your number one bucket is going to be to address insulin resistance because it is almost always present in PMOS. So again, nutritional therapist, I help people do this kind of stuff all the time. This is just a very, brief snapshot of the sort of things that we would do with someone. How that fits into someone's life is the part that requires sometimes individual, tweaking and support. So you're basically what you want to start to do, depending on, again, this can vary, how sort of aggressive you want to be or need to be about this depends on the extensiveness of the insulin resistance. Is there also metabolic syndrome? What's the person's mobility like? What's their access to exercise equipment? All of those things get factored in. But if I had to just tell someone, 3 things, it would be shift your macro breakdown. So your macronutrients, so proteins, carbs, and fats, shift that, like the composition of that, of your meals towards proteins and fats, away from carbs. Don't overdo it. Don't cut out every single carb. A good sort of, again, very general rule of thumb is like, don't go below like 50 to 70 grams of carbs a day total. So you don't want to overdo it, because if you overdo it, you can also mess up your hormones in a different direction. So, but it's very easy in the world that we live in. Our food environment shifts us really easily towards having too many carbs and too many refined carbs. So we kind of need to just counteract that by shifting that a little bit towards getting more like a higher percentage of our caloric intake from proteins and fats. So one of the things that I will do with folks that when I'm working with insulin resistance is like half the plate non-starchy vegetables, the other at meal times. The other half of the plate is split between, depending on the severity of someone's insulin resistance, the other half of the plate is split between protein and like a starchy veg of some sort. So again, that's where the individualness of this has to kind of come into play here. Is like, if someone's got really severe insulin resistance, it's no carbs except fresh fruit for a little while. If it's just mild, then maybe they can have some starchy veg like potato, sweet potato, the occasional rice. That's really kind of where it depends. But shifting where your calories come from can be really helpful, because fats do not require insulin to be metabolized at all. Proteins can get converted into carbs in the absence of carbs, but they don't strain the insulin system. And what you're trying to do is make the insulin system more sensitive again. One of the biggest ways we also do that is exercise, so or movement, if you will. So particularly level 2 cardio. You know, your intense exercise, cool, great, whatever you want to do, whatever you're going to do consistently, whatever you find fun. But if you're just looking for what most people need first and foremost is to just move more. So think about, you know, your long duration, low intensity. So what sometimes I feel like it gets a new name every 10 years in the fitness world, like level 2 cardio, if you will. So your heart rate is between about 130 and roughly 130, 150, and it's a long duration. So it's your endurance sports, you know, it's your hill walking, your cycling, your swimming, your dance, anything that you do for a longer than 30 minutes. You know, you could do it. If you can do it for longer than 30 minutes, it's probably you know, level 2, because it's really quite hard to keep your heart rate in the 160 to 180 for longer than 30 minutes. So if you can do that, great. You're probably better off than you think you are. So and again, therapeutic fasting, if it is appropriate and if you are nutritionally depleted, you want to address your nutrient deficiencies, which is another category here, before you do therapeutic fasting, because you don't want to take someone into a fast who has nutrient deficiencies. The therapeutic fasting, I would say, hold off on that until you hit the plateau that people often hit about 3 to 5 months into changing their diet and stuff. So you'll get, you know, you'll oftentimes get this like initial momentum. It'll last like 3 or 5 months, and then you'll get this plateau. Like the periods will maybe start to normalize, things will seem to be going well, and then you'll kind of hit a slump. That's when you can use a fast to kind of jumpstart the keep going and like kind of get the momentum to continue. So addressing the insulin resistance, addressing the nutrient deficiencies, symptom support, pain stuff is going to be similar to the endo piece. And then obviously acne is another big concern here. The skin tea we have is really great. The detoxi tea, which is another one of our tea blends, is really great. That one will also that is relevant to our liver health and sort of bowel piece that I'll talk about in a minute. Burdock again is great, and you would be surprised how many people do not drink enough water. So drink water, drink a lot of water, because you cannot detox without water. You have to have stuff to flush it out. That lymph system doesn't have a central pump. It moves with your movement. And so it needs water. They are the watersheds of the body, as one of my teachers used to say. So the last piece here with PMOS is hormone clearance and transport, which is all about liver and gut health. When we talk about hormones, we tend to overfocus on like hormone production, right? Do I make enough estrogen? Do I make enough progesterone? Are there too many androgens? We forget about the fact that those hormones also have to be, we can support the systems that transport, metabolize, and recycle those hormones properly. And that happens in the liver and in the gut. So support your liver and support your bowels is probably one of the most important things you can do for hormone health generally, and certainly if there's something like PMOS going on. So we have some great milk thistle capsules that are really great for that, and very gentle and good as a long-term remedy. That's a great long-term remedy. Anything bitter will do that. So your dark cruciferous vegetables, radicchio, endive, frisee, those things like that. And our best British bitters are really nice. The only time I wouldn't use that would be if someone has heartburn, because it's got peppermint in it. You don't want to use peppermint with heartburn. Jarrow pick is another digestive formula that's alcohol free if you want to avoid alcohol. And we also have a detox formula. Yeah, so we have a detox formula. So those, as far as like the products that we have off the shelf that you could like get and start, and those are all things that I would say are right. Those are forever friends. Those are things that you can take in an ongoing long-term way to support digestive health. I could do a whole class about bitters. I love bitters. Right. And, I think, my teacher, Jim McDonald, has a whole very philosophical, very eloquent series about how we have eliminated the bitters from our life philosophically. And so, it's wonderful. You should read it. But supporting your liver and bowels by eating enough fiber, eating dark cruciferous vegetables, which also help normalize hormones. They're going to help you absorb and metabolize more estrogen, so you get some of that too much out of circulation. And then some of those formulas to, again, support the liver, support the bowel, eat enough fiber, drink enough water, the basics, but that also the basics plus, some herbs. Yeah. I think that's everything on here that I wanted to say. Yeah, and again, red clover can be part of the picture here as long as someone doesn't also have a history of estrogen-dependent cancer. We don't need to be as scared of it. It can, the benefit of it, the potential benefit of it as a gentle lymphatic remedy most often far outweighs any potential risks of those phytoestrogens because they bind very weakly. And you also need adequate gut health to even break the sugar off of them to be able to bind them anyway. So yes, so those are our therapeutic kind of buckets for PMOS. This, I make it look really simple, but like this is a long road. This is a 6-month road, right? Like, so it's not something that everybody should feel like they can just turn around and do. This is why I got into this as a clinician is supporting people along this road is something that I think is really beneficial for people. Yeah. So,
amazing.
Yeah. Okay.
Brilliant. Well,
okay. That's all of our slides, I think.
Main part of the content that Alyssa has put together. It was extremely fascinating and detailed. And I think just to highlight complexity of all of the conditions kind of encompassing period health as well. We have got quite a few questions. I appreciate it is past the hour mark, but hopefully you guys will stick with us. If not, as I say, the recording will be sent out. So if you're happy to crack on, we'll start answering some of the questions that we were unable to get through.
There was some, okay, so that's the full list.
So this is the full list. So we've got any links with HEDS or heads?
Heads. I'm not sure what that abbreviation is. Hold on, let me see if I can, maybe I know it under another name. Oh, hypermobile Ehlers-Danlos. I've never heard that acronym. So Ehlers-Danlos is a condition where, it's like connective tissue is hypermobile. People injure themselves a lot. One of my favorite books of the last year, the main character was inspired by someone who has Ehlers-Danlos. Shout out to anyone who's read Onyx Storm. As far as I know, I don't actually know if that one, I think that one it's genetic. So, but the diagnosis doesn't rely on that. It relies, I think, a lot on like physical, like manipulation and things like that. I don't know of any links, specific links between that and endometriosis. Conditions of chronic pain are not going to be made any better by inflammation. So anything that's going to increase, so this would probably be the link that I would say, just extrapolating from it. I don't know any specific research papers or anything, but anything that increases chronic inflammation is going to also increase chronic pain. So that would be what I would say is probably the main thing. So your battle, it's an uphill battle against chronic inflammation, which is going to make managing the chronic pain potentially harder. So that would be, because Ehlers-Danlos also has like a significant fatigue component, that makes it potentially also, like fatigue and chronic pain have a really close link. So that would be what I would say is like you're fighting, the chronic inflammation that results from endo is gonna play into and potentially exacerbate the pain component of Ehlers-Danlos. Yeah.
Brilliant. How does menopause affect someone with long-standing PMOS and adenomyosis?
Yep. So the good news is menopause usually makes all of those a lot better because when the menstrual cycle stops, you usually get a vast improvement or up to a disappearance of those conditions. I'm not as 100% sure about adenomyosis, but like endo and PMOS both get a lot better once someone goes through menopause. Almost always, because again, your hormonal ecology changes so much. You're not producing estrogen the same way. You're not producing as much progesterone, but you also don't need it as much because you're not producing as much estrogen. So the whole sort of hormonal ecology and environment changes with the menopause transition. And so, that can be quite challenging in the sort of getting through that. But the good news is hopefully that once you get through the menopause, then hopefully it will get a lot better.
And the other key thing, going back to your presentation, was about the detoxing. In that case, you're still going to have those adhesions and
they might not be growing and shedding the same way in response to estrogen, but they are probably still going to be there. You potentially have the scar tissue, the adhesions. So it's still gonna be something you have to manage. But when there's not a menstrual cycle, there's not quite the same sort of really complex symphony happening on this timeline, right? Every single month or every, up to 45 days. And so that can simplify things a little bit, I guess. Not simple, but simpler. Yeah.
Next question from Isabella. Which diet do you recommend to manage PMOS? So I think you've covered that quite well in terms of increasing your protein.
Yeah, so I would say things that are going to help manage the insulin resistance. So which is almost, like I said, almost always present in PMOS. So minimizing your refined carbs, eliminating sugar, eating fiber, eating protein with your meals, eating meals as opposed to snacking, because your blood sugar really benefits from meals of about every 3 to 5 hours. Yeah, those are things off the top of my head. Some of it gets really individualized past that, but those are some good general. Half a plate of non-starchy vegetables will get you a long way. With bonus points for leafy greens. Yeah.
Excellent. From Natty, are there any remedies to reduce the excess of androgen?
Yeah, so the remedies are to support the clearance and the transport of those, and again to break this like cycle, to try and intervene in this cycle of more androgens creates more estradiol, which creates more, your progesterone has a harder time keeping up, and then the insulin resistance makes also more follicles. And so as opposed to, again, I want to encourage us, as opposed to like trying to like find the bad guy, attack the bad guy, which is very understandable because it's germ theory, because it's how our medicine system has sort of trained us all to think. I want you to think about the terrain, and I want you to think about like this bioterrain theory of like, how do I improve the conditions in which this is happening, and how do I support self-correction responses to the extent that I can. So I don't, there are, I think they give, birth control is very commonly used, but that doesn't really address the androgen problem. That just sort of covers things up a little bit again. So it's, so I would say herb-wise, we don't want to directly, you'll notice I didn't really mention Vitex. I had a note on the side, but it's like, I won't use Vitex with PMOS until the very end, until we've got 3 or 4 months of foundational work done. Vitex is really good. I use it quite conservatively as a practitioner. Other folks, use it a little bit more liberally, but like I will really only use it once we have gotten the foundations under some good momentum to sort of reset that hormone pulse. That's what it's really good at. Take it right away in the morning. It helps reset the FSH, LSH, gonadotropin releasing hormone. It helps reset that rhythm. So the rhythm has been disrupted in PMOS. And so when you've done the foundational work and you've reset the conditions to where they need to be, you can then give a little nudge in the right direction. But the Vitex isn't going to fix the androgen excess by itself. For example. Yeah.
Excellent. Okay. Good. From Marza, I read recently that there is a positive link between good bone health and having regular periods. Is that true? If so, what should someone do if they had years off few periods to protect their bones, especially when post-menopausal?
So I would say it's not a, there would probably be a correlative link. I don't know if there's a causal link. So I don't know maybe where that information, right? So if someone has good nutritional status and good bone density and good calcium, they're probably also nutritionally in a place where they would have good periods. So I don't know of a causative link there, but you do, bone density is one of the things that is not managed, sort of, not controlled, that's the wrong word, but like influenced by estrogen. So someone's estrogen status, right? That's why people after the menopause transition have to become more concerned about their bone density, is because I think it has to do with the calcium signaling of the absorption of calcium into the bones, if I remember correctly. But estrogen, the production of estrogen is one of the things that manages that. So that may be what you're talking about, where it's like when there's estrogen during the menstruating years, and when the menstruating years start to come to an end, you also have to be worried about your bone density because of estrogen. So that might be what you mean. Yeah.
Great. So from Lisa, can insulin resistance be an issue for those with endo?
Unfortunately, insulin resistance can be an issue for all of us, especially in our food environment, right? Where it's like there's just refined carbs on every street corner. So yes, and I would say it's even more important because insulin resistance is also a cause of chronic inflammation. So you really do want to minimize how many causes of chronic inflammation you're having to put up with. So, like a diet full of whole foods, again, half a plate of non-starchy vegetables at meals with some foods that your great-grandmother would recognize as food, to paraphrase Michael Pollan, is a great rule for most of us. And so, yeah, I would say it can be an issue, and if it is an issue, it would be important to also try and address that, because it can be another source of chronic inflammation.
Uh, and then a follow on from that is, are there any herbal treatments that help with insulin resistance?
Yeah, so there are things that can help sensitize insulin, but the treatment for insulin resistance is to make the insulin more sensitive, and the way to do that is diet and exercise. So there's things that can help, right? Berberine can help, cinnamon can help, but those are what I would maybe consider like adjunct to the core of the issue, which is fuel in, fuel out, in the simplest terms. What fuel is being put in, how much, is there too much fuel? Because insulin resistance is a problem of too much fuel in the bloodstream over too long of a period of time. The cells get resistant to insulin because they say, we can't take any more fuel in here. We're not going to let you into the cell. And so then the body releases more and more and more and more insulin to force the door to the cell open. And then that's why we get these wild swings in blood sugar. So the solution to the problem is fuel in, fuel out. So what type of inputs are we putting, and then what type of outputs are we putting our systems through? But things like berberine can help in that process. Things like cinnamon can help. I would say berberine is probably my favorite one. If I have someone who's got insulin resistance and we are also working on diet and movement, we can sometimes use that to help sensitize insulin a little bit.
Brilliant. And then from Adele, would the same herbal medication shared for endo help with management of heavy periods caused by fibroids? Yeah.
I'm not sure which of the medications you're referring to, Adele, but if you mean like the lymphatic clearance, then absolutely. So fibroids particularly oftentimes respond well to red root, because red root is very astringent. So again, it has this action of like toning and astringing, and it's also a lymphatic stimulant. So I would say if you're referring to like the lymphatic clearance component of that, yes, fibroids also can cause really heavy periods as well. So I would be on the lookout for anemia there too.
Brilliant. From Amanda, what about DIM or DIM? So we have got that in the shop.
Oh, do we? Okay, yeah, use that one.
I've heard it helps to shift estrogen into a more helpful form.
I don't use that one a lot. So, again, I think that's circling back. I know I feel like I must be like, sort of like beating this point over the head, but it's like, as opposed to looking at trying to pull one hormonal lever, look at the ecosystem. DIM can be helpful. I would say, if you're looking for something, or if we're just doing DIM and we just want another input to add to our sort of routine, it's probably not going to get you all the way there, because we have to look at the system, and we have to look at, most effective protocols from a holistic standpoint. One of the things that makes them holistic is that they plug in from multiple points, and it's the cumulative effect of that moves the cart forward. Yeah.
Brilliant. From List, would gentle exercise such as gentle yoga, Pilates help with the lymph clearance and circulation too?
Yeah.
So slightly below your kind of endurance framework, but still movement is great.
Yeah, all movement is great. All movement is going to help live. What gentle exercises may not do is help with the insulin resistance, but they're absolutely going to help with lymph clearance and circulation. One thing that is like really oddly great for lymphatic clearance is hula hooping for tendons. Right. There is no better lymphatic exercise, because you have big lymph nodes, you have inguinal lymph nodes here. And so it's just this sort of for some reason, that motion, I can't hula hoop to save my life, but if I could, I would, because it's really helpful to move your lymph. So, but yes, gentle exercise would be great for circulation and lymph. Probably would not help with the insulin resistant piece, like the insulin sensitivity piece, as much if it's not above kind of a certain level of intensity. Yeah.
Follow-on question, what role do toxins, such as those found in plastic, non-sticky stuff, play in relationship to endometriosis? Is there a link?
Yeah, so those are called xenoestrogens, and they are something to be concerned about. They act much more strongly than your phytoestrogens. So again, people don't need to be as worried about red clover as they need to be about some of the xenoestrogens. And again, they are going to be a problem in the same way that estrogen for endometriosis is all forms of estrogen is going to be a problem. They are an additional, usually unnecessary source of estrogen, because we don't want there to be too much estrogen in endometriosis, really from any source, because the lesions in the pelvic bowl or elsewhere are going to respond to that estrogen. So again, there's usually, the estrogen levels in the endometriosis are most often normal. But there is a local, there's locals like near the lesions there can be like a really high concentration of estrogen. So I would say in that sense, yes, anything that is going to, add to the pile of estrogen, if you will, when it doesn't need to do so, is going to potentially make it worse because some of those endocrine disrupting chemicals can be quite strongly endocrine disrupting. Yeah. Mm-hmm.
Amazing.
Where were
got
we?
a question to just, we've got quite a lot to get through still.
Let's see. So
It was for supporting blood. You mentioned nettle, oat straw, and what else? She missed that last point. So I think,
what did I mention? Hold
I
on,
think it may have been red meat. Just like a dietary thing.
Let's see. No, there was one. I had a supporting the blood. What did I say? What did I say? Hold on. Hold please. Um, nettle, oat straw, mineral-rich herbs. I think those were the herbs that I mentioned, and also molasses.
Molasses.
Yeah, molasses is a good one. Yep. Obviously, be careful if you have blood sugar issues. But
from List, what's your view on using ladies' mantle and yarrow for endometriosis? These are often used in certain European countries, so again, herb availability.
Yeah, herb availability. Yeah, ladies' mantle can be great. I love yarrow for all sorts of period and menstrual cycle issues. It's alternative. One of the herbalists in North America, of the like a very who contributed a lot to the herbal world. His name's Matt Wood. He calls yarrow the master of the blood. And so it really it helps with circulation. It's lymphatic. If you drink a cup of hot yarrow tea, it might make you sweat because it is also a febrifuge. So it like helps. It's I can't remember the word right now, but it helps you sweat out a fever, which is why it's used. But it's a hemostatic, so it will also stop bleeding. It was used quite a lot before we had sort of more medical ones to like stop wounds bleeding on battlefields. So yarrow is a great one. I don't use as much ladies' mantle, so I'm still getting to know some of the more European herbs.
From Jess, what are your thoughts on inositol for PMOS?
Inositol, I would say I don't use a lot of it. I would say again as an adjunct to some of these more foundational concerns. If you want to put it into a protocol, great. I think that the best use of people's effort and resources is in addressing the fundamental sort of root drivers of PMOS, right? So you can't get that, like all the supplements in the world are probably not going to fix insulin resistance on their own. However, they can be very helpful as, again, part of the picture. So I don't use it really as a first line. I'll sometimes put it in, again, if someone plateaus, or someone we need to kind of, change the protocol up a little bit 3 or 4 months in to try and kind of give a little bit of boost for momentum. But I probably wouldn't do it right from the get-go. I would do it a little bit later on.
Brilliant. Question here, which is around prepping for embryo transfer and have PMOS and endo. Is there anything especially good for that and also safe to continue in pregnancy? I have EDS and suffer with nausea and migraines. So pregnancy safe things for those two would be great, as I know a lot of us seem to get migraines and nausea around periods, pregnancy, and perimenopause as well. Quite complex.
Yeah, I was going to say, I think that might be more complex than I can answer in a question because that is multiple complex pathologies. And then you add in pregnancy, which is obviously not a pathology, but you have to you eliminate a good 60% of the herbs that you would use otherwise. So I think I'm going to have to probably take that question because I think it might be a little bit more complex than I can safely answer.
Yeah. If you reach out to us via customer form with your question, we'll try and answer it, or we can get you
we can send you
free consultation, 50-minute consultation.
Wendy does a lot of work with pregnancy. Claire McQuaid does a lot of work with pregnancy. They're probably specifically about the pregnancy piece, they're probably better versed than me in what they've also both been pregnant, so they have worked with it in their own pregnancy. So they as far as the pregnancy piece, I'm probably not fertility wise, yes. But during pregnancy and lactation, I don't work with as many folks who are pregnant or lactating. Yeah.
Excellent. Are all the herbs you mentioned for endo safe to combine together?
I would probably not combine all of them. No. I would probably. So I was trying to kind of give you a couple of examples of different categories, right? So a couple of examples of a circulatory stimulant would be cayenne, ginger, prickly ash. You maybe want to pick one. that category. And then some examples of stuff for lymphatic clearance would be, you know, violet, cleavers, chickweed, calendula, burdock. You can pick a couple of those because they're gentler. This is where it's tricky because it's not like drugs. Herbs take into account, and a herbalist takes into account someone's constitution to a much greater extent than pharmaceuticals do. So it's hard for me to say, you know, this one, or this one, because I would need to, you know, like I would need to know a lot of context about the person. That is one of the advantages of seeing a herbalist, right? Is like they take something that is, they pick, you know, of the list of 10 circulatory stimulants, I pick the one that is most appropriate for you. Maybe you are having hot flashes, and so you don't need cayenne. Maybe we find something that is not as heating, you know, maybe there's also nausea, so we pick ginger. So there's lots of little things. I would not combine every single one of those herbs together. I would maybe pick, if you're kind of out on your own, pick some of the gentler ones, you know, maybe pick a ginger, and maybe pick a couple of your lymphatic supports that are on the gentler side, like cleaver or chickweed, or, you know, get the skin tea and add a little ginger, something like that. Use more turmeric and black pepper in your food, things like that. So I would say probably don't combine them all. Yeah, because some of those are quite strong.
Yep, and also it does take a herbalist years and years of experience and study to get to a point where they're comfortable with blending lots of different herbs. Even a herbalist would tend to only blend, you know, 10 to 15 maximum, absolute maximum.
6. I'm pretty conservative on the number of herbs I blend.
So yeah, we'd always advise caution on that.
Yes.
From Jess, I have celiac disease and endometriosis with bowel involvement.
Okay.
I've always wondered if there was a link. So I think you've answered part of that. But...
So I mean, I definitely think that so with endo, I wouldn't say there's necessarily a causative link, but like your poor bowels, right? Like they're under siege from sort of multiple angles here. And again, autoimmunity, celiac disease is an autoimmune condition. Autoimmunity has obviously immune involvement. Endometriosis has immune involvement that we don't completely understand yet. So I think what I would say that is, you know, if you were my patient, right, that would send gut healing up the list of, and leaky gut up the list of priorities for what we needed to address, because there are 2 things that are potentially going on in the pelvic area there. So yes, and if you have celiac disease and you haven't been through like a really good targeted supported you know, period of gut healing and potentially you might have to eliminate other stuff temporarily as well, I would highly recommend that. The AIP is really nice. It's a pretty strict elimination diet. So again, use caution if you have any nutrient deficiencies or any sort of, you know, disordered relationship with food or anything. But the AIP is both anti-inflammatory and an excellent an excellent diet for helping to heal autoimmune diseases, especially gut-based ones like celiac.
Amazing. From Natty, are there any remedies for hirsutism?
Hirsutism. Usually, pharmaceutically, what's used is spirulactone, which can be kind of a gnarly medication. So hirsutism is probably the hardest thing to work with in PMOS. It's probably the hardest part because stuff that affects hair takes time to work. So it's like, you know, I would say, again, my first thought would be like, if we address the underlying cause and we can kind of manage the symptoms with, you know, waxing and things like that, and helping skin health generally, more than like direct remedies that are gonna like stop hair growth. What's going to stop the hair growth is addressing the androgen dominance. So, and again, which is a longer process, which I know is not the answer that, it's not like it's not super comforting answer, but the hirsutism part can be kind of, and the hair loss part can be kind of some of the most frustrating parts of PMOS to work with because they take the longest to start to get better. So other stuff will probably start to get better before that does. Yeah.
Fantastic. Is reducing wheat and dairy a good idea for endo? Do you have advice on how to reduce enzyme production of fibrin?
I'm not sure what the rationale for reducing the enzyme production of fibrin would be. Again, I think that might be like pulling on a lever as opposed to like looking at the ecology. But I think, you know, a gluten and dairy, certainly a gluten, but I would say if someone is willing and able and has the resources to do a gluten and dairy elimination is warranted. For any type of inflammatory condition, any digestive symptom, any form of flavor of autoimmunity, not necessarily forever and ever and ever, unless it's celiac, then I'm so sorry, I'm not getting gluten back. But that type of stuff is warranted, not because they are bad. Those foods aren't bad. They are just more likely to cause digestive issues. They are more likely to be pro-inflammatory, and they are more likely to be overrepresented in our diets. So when you move them over to the side, you make room, hopefully, for more nutritionally dense foods.
Excellent. And then I think this is the last question, but it does look a little bit complicated. So again, maybe
MCAS, yeah, let's see. What's useful?
What is useful with MCAS and hormones flaring symptoms, reflux, nausea, migraines, sinus headaches, runny nose and eyes? I get every time I ovulate and get my period. So yeah.
MCAS is MCAS is a histamine disorder where people have very strong reactions. Usually there's at least 1 or 2 instances of anaphylaxis before someone figures out that it gets diagnosed with MCAS. I do work with histamine issues. That is that sounds like a really complicated picture. So MCAS and hormones flaring your symptoms, that sounds like there are a couple of layers that need to be peeled back to try and figure out sort of where to intervene first. And if there's MCAS and pregnancy, and if there's multiple layers of like pathology or things going on there, that is the type of situation where it really helps to have a practitioner take a look at everything and then be really strategic about where to intervene and what to intervene with. Otherwise, what ends up happening is people come in to me and they are on a list of, I'm not exaggerating, 27 supplements, 16 medications. And sometimes in MCAS, someone ends up being on a lot of medications because there's multiple antihistamines, there's cromulin sodium. They're on 35 things and maybe, it's impossible to tell what's effective there. So oftentimes you have to kind of take a look at something, take a step back, eliminate half that stuff because it's probably not doing anything. So there's a phenomenon that I've seen, which again is very understandable, where people just think that, the solution, if something is still not being addressed, is to add more things. And that's not always the case. I think it's about, again, being really strategic, and that's something that a practitioner can help you do. Yeah.
Brilliant. Okay, well, I think that wraps up all of the questions which we received from you guys. Thank you to Alyssa for lending us an extra half an hour.
Oh yeah.
But also no, absolutely fine. It was well worth it, and I think a lot of the questions hopefully could definitely help other people as well. And I want to thank you, our audience, as always, for being part of our community and for putting forward all of your excellent questions. If you do want to know more, you can get in contact with Alyssa through Napiers. As she said, she's been practicing with us for almost a full year now. But she's got a wealth of experience and knowledge. We have got other herbalists who can help with other symptoms, and we can guide you in the right place if you so choose. If you do have general questions about which herbs to take, again, ping us an email. This recording will be sent out as well if you want to play it over a few different sessions, because I appreciate the content is very in-depth, complex, and I'm sure you'll want to go away and research it as well. But thank you very much for your time. Have a good evening, and we wish you all the best and good luck on your health journey.